Hello, my name's Sam Torgersen and I'm one of Quality Matrons. I'm going to talk to you today about accountability handover. So I'm actually on secondment. I come from Nottingham and it's something that we use in Nottingham. And I know that other organisations such as Sherwood use it as well. So actually a lot of agency nursing staff that we do have at the Trust will know about it as well. So accountability handover is about standardising the process around handover. There's two reasons for that. Is one, to make sure that we reduce variation and actually we deliver safe standards of care, and the other is so when you go from ward to ward, maybe when you get transferred because short staffing, then you know that the process is going to be the same and you can feel comfortable and slip straight into what you're meant to be doing. So accountability handover happens in two parts. So here I'm just going to bring to your attention the accountability handover sticker. This is going to replace the old checklist, the one that you fill out yourself. What's going to happen now is it's a ward-to-ward transfer, the responsibility of the sender to fill this out. It gives a snapshot in an SBAR format of all the things that you need to know to be able to care for the patient effectively. So do they have any risks? Are they a falls risk? And that helps to hand over the patient safely and effectively. It also gives you the assurance to know that you've handed over everything that you need to know about that. There's a part to sign at the bottom and that's going to help to eliminate any misunderstandings around information, and hopefully we can make sure that it's safe and effective. The other part to it is the shift-to-shift handover, which looks like this, and I'm going to come back to that part in a moment. So how we're going to do it is we're going to have our safety huddle first. That's about discussing all of the patients that are on the ward, because it's everybody's business to keep our patients safe. So if you're not their named nurse, but you need to know how they mobilise and actually if they're a falls risk, or if there's any patients that need regular turns, for example, that helps your team as well to help each other with teamwork. So if someone needs some extra help, you know that you can go and offer that to them. What I ask you to do after your safety huddle is to go and care for the patients that you are named to care for. So I want you to go and say hi to those patients, have a look, make sure that they're there, make sure that they've not gone out for a cigarette, for example, and have not returned. What we're then going to do is have a look at them, make sure that the handover that we're receiving, it matches what we see with the patient. So do they look ill? Do they look like they've deteriorated? Because our eyes tell us 1,000 things. What I then want you to do is come away from the patients and have handover using the SBAR format again. So situation, reason for admission, background and past medical history, making sure that we keep it short and sweet, because actually we don't need to know about things that are not relevant to this admission. For example, an appendectomy that happened 40 years ago, if it's not relevant, then please don't mention it. The difference with accountability handover is we hand over using our assessments. So we collect our drug cards, collect our daily risk assessments, and we use them to hand over. This is where it offers lots and lots and lots of benefits. So we're able to pick up on the things that we would maybe once have missed. So if I was on the night shift, I would give my drug card to the person who's on the day shift, and they can use their fresh set of eyes to make sure that I've not missed anything. Is there any gaps in my drug card? There might be a very good reason there's a gap. It might be that the medication is not available at the moment, but we've ordered it from pharmacy and it still needs to be given. Or because I'm human, I might have missed something. So it's the opportunity there to pick up on those things before it's too late. It takes a couple of seconds just to look down, make sure that there's nothing that we've missed, and we can rectify that before it's too late. The other thing that we do is look through the risk assessment, so fluid balances, all of the daily sheets that we need to fill in. So actually, if the fluid balance says that they've only had 50 mils today, is that real? Is that true? Is it the fact that somebody's forgotten to document, or is it the fact that that is really true and that actually the patient is being referred to the doctor and actually they need a bag of IV fluids and we're waiting for a cannula? So we can have that conversation and understand what it is that is happening with our patients, and we can question, does the fluid balance is it still needed? Is the patient able to eat and drink normally? And actually we don't need to think about it. It's about trying to reduce our workload as well. The next part to it is recommendations. So what is it that we still need to do, and any omissions? And this is where we would document. So this piece of paper will sit in the patient notes. It's got a sticker, and then for each shift, so a box represents each shift, so long day, long night, we would be documenting the things that we want the next nurse to know. So any safety concerns about the patient, so we would document in essential care information. What are we concerned about? This isn't about repeating what we've already written in the 1 to 8. This is about bringing to the attention of the nurse what it is that you need them to know. So is it that they've got transport booked for first thing in the morning? We need to make sure that they're up, washed and dressed and ready to go with all their medications for the transport arrival. The second